50-year-old male presents with complaints of right-sided ear discharge and decreased hearing for the past 3 years. On otoscopic examination, a central perforation of the right tympanic membrane is noted, and what is the probable diagnosis? Now, this is how mostly your question is going to be asked in your university exams also. So, what are the 3 things that we have to keep it in your mind when you read this question? Is discharge, 3 years, and perforation. Just by these 3, you will know what is the most probable diagnosis with my following lecture, and you are going to answer this question with confidence. These are the 3 pictures of the tympanic membrane. The first picture demarcates the difference between the pars tensa and the pars flaccida. Pars tensa is the green color one, and when the perforation involves the pars tensa, then you call it a safe perforation. The second picture shows you the 4 quadrants of tympanic membrane, which is anterosuperior, anteroinferior, posterosuperior, and posterior-inferior. So your perforation becomes an unsafe perforation, or that leads to unsafe CSOM is when it appears on the posterior part or when it occupies the pars flaccida. The third one is your central perforation, the exact perforation that's been mentioned in the question that I've given before, where it's an kidney shaped. So this kidney shaped perforation is a typical for central perforation. So this perforation is what we're going to discuss further in our video. Asking yourself, how did this happen to him? So to understand that, we have to understand that chronic infections are not something that happens overnight. It has started in the childhood, or in this case, it has been there for more than 3 years, that it was a sequelae of acute otitis media following an eczematous fever and leaving behind a large central perforation. So which means it was because of a repeated acute infection. Now, ascending infections through the eustachian tube can also be a reason, because we know that eustachian tube has an opening in the middle ear. Infection from the tonsils, adenoids, infected sinuses can also be responsible for this recurrent otorrhea or persistent otorrhea. Now, ascending infection to the middle ear occurs more easily in the presence of an already existing perforation. And that's why he's having a hearing loss added to the perforation and also discharge. Now, this persistent mucoid otorrhea is sometimes the result of allergy to ingestines like milk, egg, fish. So the reason for him could be anything. Now, coming into the pathology of his condition, what has been happening to this 50-year-old man's middle ear? Yes, the first picture shows you a central perforation in its size and position. Now, this can be different for different people. Now, this is the central perforation that I have mentioned in the question. Second one, the middle ear mucosa. You can see that the middle ear mucosa is not normal. It's red, it's swollen, it's edematous, it is velvety, and it is protruding out. So something that is edematous and it's protruding out can be a polyp. So it's a polyp, and also changes in the mucosa is also seen where you see a red, swollen, edematous, velvety mucosa. The third picture, I know it looks very complex, but it is the picture of the ear ossicles. So you can see that the ear ossicles is being damaged. The ossicular chain has some degree of necrosis. Now, what is the most common ossicle that is involved? It is the incus. You have malleus incus in stapes. It is the lenticular part of the incus that is mostly involved in the CSOM conditions. Now, coming to the fourth picture, which shows you a white chalky deposit on the tympanic membrane. Now, what is this? It is calcification, or it's the hyalinization. So this picture has a name for it that is called tympanosclerosis. So because of sclerosis, your tympanic membrane looks like this, a chalky white deposit. Now, coming to the last picture, it is about the fibrosis and adhesions. Why is this fibrosis and adhesions happening? It's because of healing. The process of healing has resulted in this, and it will further impair the mobility of an ossicular chain, or it can also block the eustachian tube, because when you hold tight something, it cannot move, and ear is something which needs movement, because of which you hear everything. Now, talking about the clinical features, the features with which the patients are going to come to your OPD. First, discharge. The type or discharge, it is going to be mucoid or mucopurulent. And the amount of discharge is definitely going to be profuse. The patient is going to say, I'm using earbuds a lot of time. I could see a lot of discharge on my earbuds. And third one is smell. It is non-fouling and non-offensive smell. Perforation, as we have discussed before, it's a central perforation. That's the most common. And mucosa of the middle ear, I've shown you in the picture where it is red, edematous and swollen. And there is going to be a hearing loss, which is of conductive type. And one unique thing that the patient is going to tell you in regard with the hearing loss is, they're going to say, I hear better in the presence of discharge than when the ear is dry. So they're going to say you that they can hear more efficiently with the discharge in their ears. Now, are they lying? No. It is due to something called round window shielding effect. Now, how is it produced? It is produced because of the discharge, which helps to maintain phase difference. In a dry ear with perforation, the sound waves strike both the oval and round windows simultaneously, thus cancelling each other's effect. Now, when there's a discharge, there is a shielding effect. That shielding effect is with the round window, and that's why it's called round window shielding effect. Understanding why he has come to the OPD, thinking about how did this happen to him, and analyzing the pathological things that is going on with his tympanic membrane, and hearing all the clinical features that is supporting your differential diagnosis, we are entering into the assessment part. The first thing is examination under microscope. And you are going to see all of the things that I've mentioned, or either you check for all of the things that I have mentioned on the side. So it is very essential in every case, and this examination under microscope provides useful information regarding the presence of granulations, any ingrowth of the squamous epithelium from the edges of perforation, the status of the ossicular chain. Is the ossicular chain eroded or the ossicular chain is intact? And tymphanosclerosis, that is the picture I've shown before, which has a chalky white deposit. And the adhesions, the fibrosis and adhesions, which is a sign of healing. Or you also check for a coexisting cholesteatoma. It's not that you see it, but if you see it, it's to be on the safer side. Now, after the microscopic examination, you check the degree and type of hearing loss with an audiogram. So usually the loss is conductive, but a sensorineural element may be present. So that is why we do this audiogram. Then moving on to the bacteriology, culture and sensitivity, we have to understand that both aerobic and anaerobic organisms can be involved. And the common aerobic organisms are Pseudomonas aeruginosa, Proteus, Escherichia coli and Staphylo aureus, while the anaerobes include Bacteroides fragilis, anaerobic Streptococci. Now, after your assessment and all of the findings that you've got from your assessment, that is from the microscope, from the audiogram, from the culture and sensitivity test, we are moving on to the treatment. We have to treat the patient, and that is the final goal of any doctor. Now, what do we do? First thing is oral toilet. What do we do in oral toilet? It is to remove all the discharge and debris from the ear. So it can be done by dry mopping with absorbent cotton buds, suction clearance under microscope, or irrigation with sterile normal saline. And the ear must be dried after irrigation. Next, moving on to ear drops. Antibiotic ear drops containing ciprofloxacin or ofloxacin are used. They are combined with steroids which have local anti-inflammatory effects. And to use ear drops, the patient lies down with the diseased ear up. Antibiotic drops are instilled and then intermittent pressure is applied on the tragus for the antibiotic solution to reach the middle ear. This procedure has to be done 3 to 4 times a day for better results. Acidic pH helps to eliminate the Pseudomonas infection, and irrigants with 1.5% acetic acid are useful. Now, care should be taken as eardrops are likely to cause a maceration of the canal, skin, local allergy, growth of the fungus or resistance of the organisms. Nowadays, resistance has become very common. That's why people advise not to take antibiotics for everything, and it is a serious note. Some ear drops, such as neomycin, gentamicin, are potentially ototoxic and it has to be avoided. Whenever you prescribe a medicine, please always remember about all the pharmacology adverse effects that you have studied, because neomycin, gentamicin, remember, they are potentially ototoxic. Third, coming to systemic antibiotics. They are useful in acute exacerbation of a chronically infected ear, but their use in CSOM is limited. Now, moving on, you have to give certain precautions to the patient whom you give the treatment. One is keep water out of the ear during bathing, swimming, hair wash. Rubber inserts can be used. Hard nose blowing can also push the infection from the nasopharynx to the middle ear, and it has to be avoided. Moving on, treatment of contributory causes. Now, what do you mean by treatment of contributory causes? Suppose the patient that have come to your OPD with CSOM also has infected tonsils, adenoids, chronic sinusitis, and nasal allergy. What do you do? Though you've treated the CSOM, the infection is going to recur again and again, because these tonsils, adenoids, sinusitis, and allergies are going to be contributing factors. So treatment of these are also very important. Moving on to the final and the definitive treatment, which is surgical treatment. Now, surgical treatment is the definitive, and you might ask me, why did we do so much before if we could have directly gone into the surgery when surgery is the definitive treatment? But the problem is, for the surgery to occur, the ear should be dry and out of infection. So to make it dry and out of infection is why we've done so much, like oral toilet and the antibiotics that we have instilled in the ear is all to make the ear dry and to keep it non-infectious. Now, not just with one week or 2 weeks or 10 days of antibiotics instilled in the ear, you're going to think, okay, it's free of infection, and then you're going to start the surgery. No. The antibiotics has to be given minimum for 6 weeks. At least for 1.5 months, you have to give the antibiotics and make sure the ear is dry before you perform the surgery. So 2 things you have to keep it in your mind before you do the surgery for the patient. The first thing is the ear has to be dry, and the second thing is it should be non-infectious. No infectious agent should be inside. Now, what is the surgery? Now, once the ear is dry, myringoplasty with or without ossicular reconstruction. You know that with the help of the microscope, you have checked for the ossicular chains if it's intact or not, and the most common ossicular chain that is getting infected or that is getting out of shape is the lenticular part of the malleus incus stapes, which is the one. It is the incus. Now, that is what you have to keep it in your mind. So, we do myringoplasty with or without ossicular reconstruction, can be done to restore the hearing. Now, closure of the perforation will also check repeated infection from the external auditory canal. Now, this is all about CSOM. Finally, in this video, you've learned the overall concept about CSOM, and I hope that now if you rewind to the question that I've put in the start of the video, you will definitely be able to answer what is the diagnosis, and after the diagnosis, what are the investigations you're going to do, what are the pathology inside it, and why did this happen? That is the etiology of it, and what is the treatment, what is the definitive treatment, and what is the precautions for the treatment. I'm sure you're going to answer all of these questions and rock in your exams. But in addition to all of this, I want to give you this 10 questions which I want you to work out and check if you are strong with CSOM. So this is all about CSOM. Hope this video was informative and helped you all in and around CSOM. So this is all. Thank you so much, and bye. This is Amo from Med School.